Hi, welcome to the Dog Dave Show. Today I'm excited on the show because I've got Dr. Steve Lun. He's a urologist. We're going to talk about prostate cancer today. So ladies and gentlemen, welcome Dr. Steven Lun. Dr. Steven, pleased to meet you. Thank you for coming.
Welcome.
Thank you. Take a seat, please. Well, we appreciate you taking your time to come to the show today. It's quite an honor, actually.
Oh, it's a pleasure to be here.
Yeah, thank you. You are very much well-known urologist, right? Believe me or not. I mean, I'm a family physician myself, so I know you very well, and we hear good comments from the patients. And when I spoke to you the other time on the phone, you said you're passionate about prostate cancer, which has become now the second most common cancer in men. And looking at the data here, it says about 21,000 per year in Australia, cases identified each year.
That's the newly diagnosed number.
That's right.
And we lose about 3,500 people per year.
That's correct. And the average cancers detected normally on those age group of 55 to about 60 or something like that?
It varies quite considerably. The prostate cancer range goes from sometimes the early 40s all the way up to 80s and 90s.
That's right.
The youngest patient I've ever seen was 37.
37? How was that detected? Because now there's no proper prostate cancer screening program, is there?
He was a relative of another patient, and
Yes.
When there's a first degree relative involved, there's an 8-fold increase in risk. So
Yes.
we usually recommend to the relatives of cancer patients that they inform their family.
Yes. So there's quite a strong genetic component to it.
It's very much so.
That's right, yeah. And also in my case, I think I've seen, like you're saying, early 40s who came, they elevated PSA and turned out to be cancer, and some of which was aggressive, actually.
And usually the younger patient has more aggressive disease.
That's right.
So this is where it's quite significant in that there's a lot of talk about prostate cancer, a lot of controversy about the PSA test.
That's good.
And the people who tend to listen to all this controversy are the younger patients because they're more afraid of outcomes. But in reality, they're the ones that have to be checked because they have more to lose.
Right. According to some data here, the reason why we do PSA is basically based on an individual basis. Patient asking for a PSA. What of those who don't know anything about it?
In general, patients should be informed about PSA before they actually have it done. So they have to be informed of the possible benefits, the possible outcomes and risks involved if something is found. But that's purely on the carcinoma side of things. Many patients who have elevated PSAs also have benign prostatic hypertrophy as well.
That's right.
So the people who argue about PSA never take that into account. And I think that's quite important because most of these people have some pathology of some sort.
Yes. So we, as family physicians, we send somebody for test, the PSA, which is a simple blood test now. We don't do the digital rectal examination anymore. So send them a simple PSA test. It comes back elevated, maybe 11, 12 or something like that, and the gentleman doesn't have any symptoms at all. But we proceed to do an ultrasound scan, which is a basic thing we have to do. And then we refer to you. Where do you take it from there?
Most of these patients will consult. We'll take their standard histories, and there's sometimes very specific symptoms we find in the urological finds. They may not be volunteering symptoms, but they may have symptoms.
Yes.
And we'll do the check up their investigations to date. Typically, we will do a digital rectal, mainly because we do them all the time and are fairly confident in what we find.
Yes.
But typically these days, we will be asking them to have a 3 Tesla MRI. So a 3 Tesla MRI is a relatively new investigation that's only been around for the last 5 to 6 years.
Right.
And it's the most advanced MRI imaging there is. Some of the less scrupulous radiology practices will argue their lesser machines can give you the same information as these more high-powered machines, but you can't see the same data.
Yeah. Is there a cost in Australia? Is there a cost to the patient for that MRI?
In Australia, since middle of last year, MRIs of prostates essentially have become free because there was a government rebate given, and the radiology practices in competition and bulk billing each other for it.
Right. So you do the MRI now, you analyze anatomically, look at the organ there, and see maybe there's a change or a shadow or something like that. Yeah. And where do you go from there?
Well, the MRI is a very complex test. It's a multi-parametric test. So MRIs are magnetic field-driven images.
That's right.
They have the so-called T2 series, which are the actual images that most MRIs will give you, where there's a pull on the tissue and they produce these grey tone pictures. But the beauty of the multi-parametric fields in the prostate area is that they look very carefully at the apparent diffusion coefficient films and the so-called B1400 films. So the apparent diffusion coefficient is a measure of the water molecule movement through tissue.
Right.
So they're pulling water molecules through the tissue.
Right.
And normal tissue, there's fairly free movement. But if you have restriction, typically it's due to blockage, cancer, destruction of tissue. And these deficits show up. So in combination with the original T2 series films, plus the ADC restriction films, you start to get a very strong feel of something going on. And they use a contrast infusion to see the blood flow, and if there's an increased vascularity showing up in the same area as there's any deficits, it becomes quite apparent that there's something bad going on.
Right.
So the sensitivity rate of finding a lesion by the MRI is, if you've got a carcinoma, 85 to 92% of people, it will show up.
Yes.
If it's negative, it's truly negative 97%.
Well, okay.
So it's a very good test to say you've got something or you've got nothing.
That's right, yeah. So do you still proceed to a biopsy in that case?
If there's a suspicious lesion, most times we'll ask the patient to have a biopsy of that lesion. And we can use the MRI. Unfortunately, it's a little bit expensive at the moment because we don't have a government rebate for that. Or we can do more standard ultrasound-based targeting.
Yeah, that's right. Okay. All right, so you've done the biopsy, they've done what's called the Gleason score to grade the tumor.
When the pathologists have a prostatic biopsy and there is a positive finding, they give us a score called the Gleason score, which is looking at the cell patterns. And the cell patterns go from very normal looking to very abnormal looking, and they give it a grade of 1 to 5. And the Gleason score is a combination of the two most popular cell populations. So it gives you a rough guide of what the activity of that tissue is like. And so a Gleason 5 or less carcinoma is basically going to act like a benign tumour. 6 is intermediate, 7 is getting a bit more advanced, 8, 9 and 10 are terrible. Yeah,
so we got, let's say a score 3 to 5, which sounds like benign. We just a wait and watch thing, game from then on?
It's very patient dependent, what advice we give. If somebody had a Gleason 6 cancer, we're going to be offering probably more conservative advice if the circumstances are correct. At the moment, it's advised to have reasonably conservative treatment if it's a very focal, localised Gleason 6 carcinoma, and the patient has other comorbidities. When nothing else is going to interfere with them. But you have to be careful on the very young patient, in that if you have a very young patient with a Gleason 6, this position of being fairly conservative and watching them is called watchful waiting. In that watchful waiting program, some people in Australia just watch them with the blood test and just keep watching them. But that's not how it's supposed to be done. You're supposed to do repeat radiology every year, repeat PSAs every 6 months, and repeat biopsies every year.
Well, that puts the patient in even higher risk, isn't it?
And for these patients who go into this watchful waiting program, if you look at the statistics from overseas, in large scale numbers, within 2 years, 80% of people have probably elected to start treatment.
Okay.
And what happens is to elect for treatment, there has to be a deterioration in the PSA level, the Gleason grade goes up, or there's evidence of the disease getting more advanced.
That's right. If, for instance, let's say the PSA goes down, you still wait and watch again?
Yeah, if it decreased, we'd be quite happy to continue watching.
Yes. Right. With the complication of the biopsy, for example, maybe impotence or bleeding or infections or something like that, is that a common thing in your profession?
It's common to get bleeding from the biopsies, a little bit of blood in the urine, but it's very temporary. It's not a major worry. Right. The major worry is infection, and all patients who undergo prostatic biopsies have to be covered fairly well for infection. So we standardly give them one of the quinolone agents pre-operatively and post-biopsy.
Yes.
And if we're doing the MRI biopsies, we're actually giving them an intravenous dose of antibiotics at the time as well.
I know you're well traveled, going outside the country for conferences, in particular you said in the United States. Are the protocols pretty much the same in terms of prostate follow-up?
Yes, the leaders in the world in our field are the American Urological Association, and they look at their guidelines for just about everything every 2 or 3 years. They go through their guidelines repeatedly to see if there's any. So they change their indications if there's any new data that comes forward.
That's right. Okay. So, I mean, the whole point anyway is detection, because early detection also means early management. But where do we come in? I mean, some men they're watching, maybe they'll say, oh, I need to get my PSA checked. Should that be the case? Just tell the doctor and say, okay, can I have my PSA done? I'm worried about prostate cancer. It's now second most common cancer among men.
Screening for prostate cancer is a little controversial. The recommended positions of the Australians and the Americans urological associations is that anyone over the age of 50 should be offered a PSA if they desire after being informed about the test and their findings. And when there's an affected relative from the age of 40. Now, over the years there's been a lot of controversy about PSA because it was used willy-nilly as a guide for testing for prostate cancer. If you look at the figures, if somebody has an elevated PSA, about 33% have carcinoma.
33%.
33% will have benign growth, and 33% will have infection.
So there's lots of false negatives.
So as a guide for cancer, that's where it was hammered, and a lot of people were jumping on the bandwagon saying, well, it's a worthless test. But it's a very good test because since the PSA was released commercially in 1987, the death rate from prostate carcinoma fell by 45%.
Wow, that's good.
There is no other disease ever that's had a death rate fall that high.
Wow, yeah, that's significant, isn't it?
So they can't say it's a bad test when that happens.
No, that's right. Yeah, so that's where the controversy comes in now. We're seeing the benefit of it. Like I said, I've had patients who are just over 40. Diagnosed with cancer, one of them had radical prostatectomy anyway, and it's still okay. He's got a few issues, but it's still all right, Yeah. So you save life. If we just passed on and say, forget about the PSA, we talked him down not to have it, he'll be probably dead now, but maybe.
A young patient will not survive.
Yeah, that's right. Yeah, so I think it still needs to be done. But we always give a disclaimer on this show, as usual, because what we're talking about is just general talk. The idea is for public awareness and public knowledge. So your situation may be different, okay? So you need, in your own right, to talk to your healthcare provider, your family physician, and discuss your own situation. So this is just a general talk. We're not prescribing anything. We always put that disclaimer first, So go on, sir.
So I think the controversy has settled a lot since the MRI has arrived, in that they were getting quite heavily involved with this watch waiting programs, trying to figure out who should be in or not. But to me, the MRI lets you see the lesions. If you see a lesion on MRI, you've got a significant lesion. This is not a little itsy-bitty one that may not do anything to you later. They're quite significant.
That's right. And usually the prostate grows, then goes to the back and then the spine, and then progresses from there on.
Prostate cancer has a very strong affinity to spread to the skeletal system. Then it goes to the lymph glands, and it can start obstructing the retroperitoneal structures such as the ureters and kidneys.
And by the time now, you as a surgeon now, you pass the mark now because
we can slow it down. We can't cure those patients.
No, you can't. That's true.
And the good thing is today, not only has the MRI changed our outlook on life in terms of we can see what's going on. There's been an accompanying test that's arrived at the same time, the PSMA PET scan, which is a PSA-derived ligand, from which we currently use with gallium. It shows up extremely small deposits way earlier than any of our previous testing. So in the past, we were probably a bit guilty of over-treating patients who have higher PSAs in the hope that there was a chance of saving them, because the scanning technology at that time wasn't showing any spread of disease. But this new PSMA will show you these lymph node affected people way earlier.
Should the family physician be ordering that, or it's a specialist order only?
It's really there after the diagnosis of prostate cancer is made.
Yeah.
So if you think you've got a fairly early localised carcinoma with lower PSAs, you probably don't need the PSMA at that stage.
Yeah.
But if you've got an intermediate level PSA, say 15 to 20, it is very much appreciated a PSMA at that stage to say whether we can treat this patient or not.
Yeah, that's right. Can I just take you to the basics? Okay, so there's a gentleman there, he's having trouble passing urine. How would you advise that gentleman? He's having trouble.
These patients who've got obstructive symptoms, we've done the full history investigations. If they don't appear to have a prostate carcinoma, they can be optioned with either, they can continue with their symptoms if they desire, they can try medical therapy with tablets if needed, or they can contemplate a surgical intervention with a traditional resection of the prostate.
That's good. And how's the outlook regarding prostate cancer? Yeah.
It's for many years we've been a bit static in terms of the long-term outcomes, in that the early cancer we can treat quite well with surgery or radiotherapy, in particular with the radioactive pellets these days and brachytherapy. But the long-term results with advanced cancer, we've always been a bit stagnant and there's not been a lot of change. And that's why we still have 3,500 people die from prostate cancer a year, which is twice the amount of people who die from breast cancer a year. But coming down the line, there's been a lot of research, and it's been led by one of the Melbourne teams, the Peter MacCallum Institute. There's a derivative of the PSMA PET scan. They've got it in another substance called lutetium. And lutetium is a radioactive ligand, and they're giving this to advanced cancers, and they're doing incredibly well with major metastatic deposits.
Okay.
It's almost the same as when we used to see patients with multiple lesions after testicular carcinoma. Typically people that show up with cannonballs in their lungs. And when the chemotherapy for testicular cancer was first developed, that would disappear. Well, with this lutetium, they're finding the same results. So down the track, I think there's going to be huge possibilities with the advanced cancers.
Yeah, that's very good. I mean, it's a man disease. As we get older, there are higher chances of getting of having these prostate problems anyway, whether it's benign or cancerous scenario, basically. So, what advice can you give to the men watching 40-year plus or even under this?
I think the major thing I see from the patients referred in, they don't talk to their family physicians early enough.
That's right.
If they talk to the family physicians, they can get some general indication of maybe something's going wrong, or they can get referral at the adequate time. They don't need to put up with troubles. That's
right. And also family history. Family history is very key here. First degree prostate cancer definitely is a very high risk factor. Anything else you want to tell the audience, people watching? Dr. Lun, we appreciate your coming. Anything else, advice?
All patients have to have a good general family physician. It's very hard to operate in isolation And if they don't see their family physician, they can't expect good outcomes.
That's right. That's right. I don't know. I do it differently anyway. I don't know. I could get a slap on the back of the wrist, but I encourage all my men to say, you need a PSA at least.
I think it's made a huge improvement in men's health outcomes.
That's right. Yeah. I mean, over 40, not everybody. Yeah.
It's quite intriguing. There was a group in America called the US Preventative Task Force Group.
Right.
Sounds very impressive. They recommended in 2012 not to look at PSA. And they based it on the studies. There were two randomised controlled studies looking at PSA screening, one from America, one from Europe. And they're a little bit biased because they like the American do-it-yourself studies.
That's right.
But the American study, the PCLO study, was heavily flawed, looked at about 150,000 people, and they showed no benefit in looking at PSA levels.
Well, that's a small number though, 150.
Well, it's big enough. Whereas the European study looked at 250,000 and had a 10% improvement early. It's gone up to about 15 to 20% improvement in survival now.
That's right.
But there was a few flaws because it was multi-country and they had a little bit of difference in selection criteria to get into the study.
Yes.
But the American study was later to be found to be seriously flawed in that just about every single person on that study had already had a PSA level done. So all the bad disease was already picked out and taken out of the equation.
Yeah, so it doesn't work. Yeah.
And so in early 2018, this US Preventative Task Force Group reversed their decision of 2014.
That's okay.
Sorry, 2012, sorry. And because what everybody around the world have been seeing is a much increased rate of metastatic disease presentation. So from their recommendations, the disease became much worse.
That's right. I don't know, from your clinical experience, I don't know, is there ethnicity issues regarding prostate cancer? Is it more common in some races than others?
In our local treatments, we've not seen too much variation, but the population studies show that the black African American Negroes is very, very bad.
Right,
very high rate of disease in that population. And some of the Scandinavian countries are quite high as well.
That's right. I wonder why. Could be the dietary, could be anything, isn't it?
They look at all these things, but haven't quite. I think it's diet and genes.
Genes, yeah, that's right. Well, there you are. Just a talk, and all the gentlemen out there, you've learned something about it. The prostate cancer, basically, it's a simple blood test, but you need to discuss this with your healthcare provider. Don't go and Google and look at stuff, and talk to your healthcare provider and work out a program for yourself that suits you. Everybody is different, okay? We would like to thank you, Dr. Lun, for coming to the show, and it's always a pleasure. We never know, we might grab you again for other talks, but we really appreciate what you're doing, and God bless you, and go well. Thank you.
Thank you.